Hello, Southern California. Beth said you were a lively crowd, so I'm not so sure about that, but I'll take it. It's time for This Week in Microbiology. This is episode number 90, and we're recording on October 26, 2014. Hey everybody, I'm Vincent Racaniello, and you are listening to TWIM, the podcast that explores unseen life on Earth. Today we're coming to you from La Jolla, California. We're at the annual meeting of the Southern California branch of the American Society for Microbiology, affectionately called SCASM. You guys like that name, SCASM? Yeah, you do? Okay. So I was asked to come here and do a podcast. We've got two of the speakers from this wonderful meeting, and we're going to talk with them about what they're doing. And we also have an audience, a very enthusiastic audience, right? Anybody here heard of TWIM before? Hey, not bad. Well, up on the screen, you can see a link to where you can find it, microbeworld.org/TWIM. We do this every other week. As you heard, we're up to episode 90, and you can find them all there for free. You can also find them on iTunes, so check them out. I think you would like it. And this will be our second podcast that deals with what I would say clinical microbiology, epidemiology. So if you want more, listen and write in and send us emails. We have usually lots of emails, and we answer them on the show. But today we are time constrained, so we're going to get right into our guests. So my first guest on my right, she is the Chief of Acute Communicable Diseases in the Los Angeles County Department of Public Health, Laurene Mascola.
Yes, thank you.
Welcome to TWIM.
Thank you very much.
And on her right, he is the Executive Vice President and Chief Medical and Technology Officer at Cepheid.
Cepheid.
Cepheid. David Persing.
Cepheid, yeah.
Welcome.
Thank you.
Say, I have to get this right. Cepheid?
Cepheid.
Cepheid. What is Cepheid?
Cepheid is actually it's a astronomical term that relates to a pulsating star.
Okay.
That sends out light at a very defined interval. So it's sort of a chronometer for the universe.
Why was the company named after that?
It's a good question. There are varying theories, but one of the founders was into astronomy and thought that it was a cool sort of standard bearer for the universe.
As good as anything else. I want to start out by finding a little bit about the two of you, where you came to be where you are today. Let's start with you. Where are you from originally?
Sure. I actually grew up in the Bay Area, Saratoga, California, which is in Silicon Valley. I grew up there when it was mostly apricots and prunes, and then kind of watched the valley evolve from that. Went to medical school at UC San Francisco. Started in 1980, joined the MD PhD program there, and did 2 years of med school, then went to graduate school, started all over, went to graduate school, worked in the lab of Harold Varmus and Don Ganem at UC San Francisco. And then we went through that when it was about 1986 or 87, and I was in the tissue culture lab doing work for my thesis, and heard this NPR broadcast as it was going through on this new thing called polymerase chain reaction. And Kerry Mullis was on the radio. He's kind of crazy, but sorry, Kerry. But actually, I was listening to that, doing tissue culture, and worried about getting out my thesis done on time. But I thought, this is really an amazing thing. I think I'm going to specialize in that. So I did. And when you graduate, when you graduated and came out in 1988, and you knew the difference between PCR and CPR, you were like the Heisman Trophy winner for the year. So I got to shop around for residency programs. I came up with a very nice arrangement at Yale, where I could actually have a lab and a tech while I was a resident. So that enabled me to keep publishing while I was still a resident. So that was a good move. And then ultimately, I planned to stay at Yale after that, but then got an offer I couldn't refuse from Mayo, and that it was where it really started.
And since then, you have worked on PCR, basically.
Yeah, molecular diagnostics has been my career, and was at Mayo for about 10 years, and then left really against medical advice from my Mayo colleagues, leaving the eternal security of a tenured position at the Mayo Clinic to jump to the dark side of industry. And that story was because of some technology that we licensed from Mayo to a company in Seattle, and I came into my department chairman at that time and said, you know, this technology is really cool. It's this microarray technology that I'd like to learn about, and it was new back then. So I need a sabbatical, and he says, well, you know, Mayo doesn't have a sabbatical program. So I just made the leap and was there for about 5 years. The company got bought by GlaxoSmithKline, which is a happy ending. And then right after that moved to California, back to California, back within a few miles of where I grew up, to work at Cepheid.
I want to talk to you about some of the cool work you're doing with PCR. I have to tell you, though, when I had my lab, I started my lab in 1982, and PCR was just beginning. We had homebrew PCR makers with water baths, and you would move the tube manually from one to another. And when listeners hear what you guys have developed, they're going to be amazed.
Yeah.
It's really different. How about you, Laurene? Where are you from?
Well, I'm from Brooklyn, New York, for those of you who wouldn't have guessed. And basically was the first one in my family to go to college. Was actually discouraged from going. It was way better to get married, I was told. So, but I fought them, and I went to college. I went to med school, you know, against all my parents' wishes, and finally wound up in California from New York to go to Children's Hospital of Los Angeles, where after doing my pediatric residency, I was going to be a pediatric gastroenterologist because I thought working with livers was really cool. And but I first did a trip around the world for about 1.5 years, and I started out, you know, in California, and went to Taiwan and Japan and India and etc. And somewhere along that way, I decided, God, you know, being a private pediatrician for a lot of people that have like less than 1% of the problems of the world really seemed like a selfish thing to do. And I canceled my fellowship. I called my mother and I said, get me someplace at UCLA so I can get my master's in public health. And I got in. Then I went to, of course, CDC's EIS program. And I was in Atlanta, Georgia for a couple of years working with CDC. I made some great connections, and then went back to California, where my family was, and have been working in the Los Angeles County Department of Public Health, same building, same floor, for the last 28 years. Different offices, but working in conquering diseases that have continued to surprise even me in their diversity and the way they can affect people and our lives.
So it's a good thing to take an interruption in your career sometimes.
It actually was very good. I think they call it something now. It's got a term. In those days, it was called being weird. But now they actually have a term for when you take a year off from college. What's that called? There's some term.
It's not a sabbatical, right?
It's not a sabbatical, but it's actually something that's an important thing for you to do when you're out of college. But I did it anyway.
Yeah. No, it's great. And then, so would you say you're an epidemiologist now?
I am definitely an epidemiologist and an infectious disease epidemiologist and working in public health.
But you don't take care of patients, right?
I do not see patients except for my grandson and my children when they were young.
Of course. And you're half Italian?
Half Italian, half Jewish. So the best of both worlds. Guilt.
It's a great
guilt
combination.
On both sides, and we use our hands, and we have a lot of great food.
No, it's a great comment. Your characteristic, I think, is the Italian side, but I'm biased by being Italian. But I was thinking, listening to hear you speak before, that it's clear that you have half Italian and half Jewish, because they both come out. It's great.
Yeah.
It's just wonderful. So let's start with you and talk a little bit about what you do. And obviously, as you said today, everyone is talking about Ebola and all the other interesting infections that earlier this year we thought were neat, like MERS, even chikungunya. You didn't mention
I
chick.
didn't even have time for chikungunya. I mean,
it'll probably be here eventually as well, right?
It could be. I mean, you know, over 300,000 cases in the Caribbean. You know, I would not vacation there currently. You know, it luckily has no case fatality, but the name itself, chikungunya, actually means crippling disease because you have such severe muscle aches and body aches, and you do recover, but it can be a while. And again, another mosquito-borne, you know, vector that we have here in Southern California and in other parts of the U.S. So the vector's here. All we just need is some people that are viremic at the time for that mosquito to bite that person and bite another, you know, incidental person. We've seen cases in Florida, which are obviously the closest to the Caribbean.
These are imported cases, or they're
they're endemic cases.
They're endemic
cases, right?
Okay.
We always have imported cases, but they have currently had endemic dengue and chikungunya in Florida.
So do you have a surveillance program for chikungunya here?
We have a surveillance program. We do sentinel chickens, where we actually look mostly for arboviruses like West Nile, La Crosse, and St. Louis encephalitis. But I'm sure if we came across chikungunya, our lab would look for it as well.
So you have sentinel chickens for chikungunya.
Sentinel chickens for chikungunya. There you
so that
go.
means they're at certain places you have a cage with a chicken in it.
Yeah, the
and then you
chickens,
periodically you go and
bleed them.
Bleed them.
Yeah.
And are these on buildings or on the ground, or?
Well, actually, one's actually on the roof of our public health department building in a little cage. But you know, there are scattered throughout LA County, and they're treated humanely. Just want to make sure that they're treated humanely. And you know, some people use their eggs a lot, but.
All right, and then you bleed them periodically. You look for antibodies to chick.
We look to antibodies for different viruses. Correct.
Not just chick.
Not for we use arboviruses, you know, as I said before.
And if you find something, what would you do?
Well, then we publicize it. You know, we also look at, you know, our sentinel chickens. We look at mosquitoes as well. You know, we look to survey them to see what viruses are circulating. And then we obviously, you know, announce to the public through communications to say, please wear, you know, DEET or mosquito repellent, get rid of standing water, all those things that most of us don't do anyway, but we try to emphasize doing it. I now, you know, people over 65 are at risk because, you know, our T and B cells don't work as well anymore, and I keep putting that DEET closer and closer to my door, but not yet on my body. So it's hard to change human behavior no matter how much you know about it.
So I understand in Singapore that they have standing water squads that go from home to home, and if they find standing water, you get a big fine.
Right.
Of course, we can't do that here in the U.S.
No, we do. We actually do it. In LA County, we have a mosquito abatement districts that actually go and do look for pools and standing water and do have some type of degree of enforcement.
But
so
they don't fine, but they won't fine you, will they?
I'm not exactly sure. I think they can give you money fines.
So tell us, Los Angeles County, that's where that's your jurisdiction.
That's right.
Right, and is that a larger area than the city?
Oh, yes. So the city's about 2 to 3 million, you know, and again, LA County is bigger than 42 states.
Okay. So you tell us a little bit about your Ebola surveillance. You talked about it here before. I want our listeners to hear how this is being done because we haven't had anyone on any of our shows that knows anything about it.
Well, I mean, obviously, it's very complicated because, you know, in LA County, you've got about 20,000 physicians. You know, we have 100 hospitals, and you can just magnify that by how many ED doctors, you know, go through 3 shifts a night in these different hospitals. And we just keep trying to sort of plaster their walls with our phone number, these are the questions, and we are making face-to-face contact actually in a tiered approach with, you know, large hospitals, smaller hospitals, actually going out in teams with nurses and epidemiologists to actually just make sure people know the basic questions to ask. The 3 screening questions: what countries did you come from? Were you a healthcare worker? Did you come in contact with an Ebola virus patient? And then do the appropriate thing to protect themselves, protect the other people in the emergency room, and obviously to protect the health of that person. So that's our first step, is just getting people to identify people that might be at risk and then phoning us and knowing that phone number. And I wish I could tattoo it on people's arms because you can't believe how many times people call the state or the CDC before they finally call the local health department. But we are your resource. Every local health department in the country is a place you should go to. Don't go to the CDC first. Don't go to the state. Come to us, and we'll help you out.
So every every state in the U.S. has a local health department that
well, it
can
depends.
do this? It depends.
Exactly. Every state has the health departments arranged differently, whether they're, you know, decentralized or centralized. And here in California, obviously, we're decentralized. We do have a state health department, but then we also have all of our local health departments, which have local jurisdiction, like San Diego has its own health department, Riverside, San Bernardino.
So yours is a state health department. You take care of the whole state or just Los Angeles?
Just Los Angeles.
So what other, there's San Bernardino, you said?
They have their own, you know, information that they work through with their residents.
And each of these health departments has to have preparedness programs, just like we're going to talk about for Ebola, right?
Exactly.
And would this apply to every health department in the country, more or less?
I think every health department across the country has been working 100 hours a week to be prepared, to be ready, to have some designated hospitals that are up and running to care for this disease that potentially could be very infectious if not treated appropriately with respect to appropriate infection control.
So that's really a remarkable statistic that every health department has to react and get training. And who starts this, or is it individually initiated in each state?
Well, you know, I can only speak for, you know, Los Angeles and the state of California, but obviously, you know, we've been getting missives from the Center for Disease Control for many, many months to tell us, you know, this is what you need to do, this is the guidance, inform your doctors. There are different health alert networks, like I was saying before. The Center for Disease Control has its own, you know, health alert network. State of California has a health alert network, and hopefully physicians, laboratorians, anyone who wants to can sign up to receive these alerts and participate, and then it's just our role to browbeat people into responding to them.
So you're an overseer, really, because the hospitals are seeing the patients, they're carrying out the tests, the diagnostic tests, but you get the results as well, correct?
Well, actually, they can carry out the tests without going through us. So there are a lot of tests that sort of have to go through the LA County Health Department, because otherwise our poor laboratorian here, Nikki, would be going crazy. But, you know, we have to pre-approve, otherwise everyone would want the Ebola test, you know.
So a test like that, or even a MERS test would have to go through
MERS test, botulism testing, you know, not everyone can get it if they want it. They have to meet certain criteria.
Right. Okay. So before you guys had to train for Ebola response, what was the previous virus, MERS?
MERS was the virus of the day, right? And then there was the enterovirus actually sort of interspersed itself in between MERS, and we had to have our algorithms, and we also had that, you know, comes up through us before it gets sent to the state health department, which currently is the one that does the testing, the subtyping. Okay.
And did you do a chick preparation as well?
Not yet, because it's way far away in Florida. So
well, we know how that works, far away, right?
Far away could be tomorrow, but right now, you know, we've got enough on our plate. And as I said before, the good news, bad news about chikungunya is the same preparations we're doing for all our other arboviruses should work for chikungunya, you know, in the sense of just get rid of mosquitoes.
Okay. Now, what about influenza? Do you have a preparedness for that as well?
We always have influenza preparedness. That's something that comes every year, just like taxes. I mean, you know influenza is going to come. You know, we know the vaccine programs. In fact, we work with one of his programs as well, looking at real-time diagnosis. Like he mentioned earlier, in one of our Department of Health Services hospitals, when a patient walks in, they can actually get information about their Ebola status. It goes into a cloud. It can be accessed by both the public health department as well as the practitioner, and if populated throughout, you know, let's say many sites, you could actually see in real time which areas of the county, which is over 4,000 square feet, are experiencing disease occurrences, because even though we think globally, disease acts locally. And so it'd be really interesting to see in a real-time fashion, as these tests get more utilized more frequently, that we can predict disease, you know, by census tract.
All right. So on a typical day, what do? You get up in the morning.
Yes.
You drive to work.
On a typical day, you know, you listen to the news, because that's going to dictate your day. You know, whatever is being, you know, read on the news, you know, if it leads, it bleeds, that's what's going to make your day. Because basically, we do have to respond to a lot of things that you hear in the newspapers, and then obviously you start reading. Luckily, on the West Coast, we can get, you know, a head start on all the things that have already happened in Atlanta. We're 3 hours ahead, you know, so we could, or behind, so we can actually see what's happening. So we have to start reading all those notices, and then we make our plans for the day of what we have as our top priority, because the rest of the diseases still go on. Foodborne disease go on, you know, meningitis goes on, the bread and butter diseases of public health, TB, STDs, all those other diseases go on, but we still have to right now prioritize those that are most important.
So the other day when New York reported a case of Ebola, did that have an effect on you guys?
Obviously it had a significant effect because, you know, the politics of that ramp up, you know, the factor of what happens here in LA. Do we have people? But I think the good news for everyone to know is that a couple of days ago, the U.S. government, you know, made a decision that all people entering the country from those affected countries are now funneled through 5 airports. All people that come from those 3 affected countries are funneled through 5 airports where they're actually screened by a Center for Disease Control quarantine person, and their information is then sent to their state health departments that then sends it to us at the local level, and we monitor these people who have no other risk factor except what we call country associated. And then we monitor them with either phone call, virtual, whatever, cell phones to see that they are monitoring their temperature. So I think the nation should feel very comfortable that we really have most cases of people coming back are being monitored, and that there should be calm, and that we should really just work to find a vaccine for this disease and to help those countries overseas that are really dealing with the brunt of this illness.
So California must have military personnel, healthcare workers, physicians volunteering who are working in that. So, but they don't enter the U.S. here. They enter at one of the 5 other airports, I presume.
Well, they don't enter LA. That's correct. We have no direct flights from Africa. So, you know, and before there were many other points of entry, but now in the U.S. there are only 5, Dallas, New York, Chicago.
So a returning physician, say, from California would go through New York. It would be screened, as you said, because he or she came from one of these 3 countries, and then would be allowed to proceed here.
That's right. We'd be allowed to attain public conveyance, come to Los Angeles. The state would forward the information to us, and we would then make contact with them and continue to follow them for 21 days. And depending on their physical status, would be allowed to do as they please, be allowed to go back to work, or else not be allowed to go on public conveyances like planes, buses, etc.
So if one of these individuals suddenly developed a fever, and you said it's 100 degrees or 101 and higher?
Well, it's 100.4 for cases. What we're looking at now for contacts, which is now 99.5.
Okay.
And in some parts like New York City, they're even seeing any fever. So, you know, the epidemiology is being written as we speak, because I said earlier, most of the data is coming from Africa. And again, it's not, we really don't know about early cases in Africa, because by the time most of those people reach healthcare facilities, they're usually late in their disease. But here in the U.S., we have the luxury of seeing the minute a person gets a fever, we know about it, and a lot of times they test positive when they're less than 100. So we keep changing our fever recommendations.
Okay. So let's say an individual came here to California, to Los Angeles County, developed a fever. You would find out relatively quickly, hopefully within a few hours, because they would tell you. Then what happens next?
We already have plans in place for how they would be transported, through which type of setting, what emergency service ambulance would take them, and to which one of the few designated hospitals that we have in Los Angeles County that are prepared, trained, drilled, and have appropriate point-of-care testing for the laboratory section of this, have appropriate PPE, and have people that are ready to take care of this patient, and we would appropriately transfer that person for care.
And then one of the first things to be done would be a test for Ebola infection.
That's correct.
Which is it a PCR-based test?
Yes, it is a PCR-based test. And actually, Nikki Green, our laboratory director, said that we are one of the few hospitals in the nation, not hospitals, laboratories in the nation that are proficiently trained to run that test.
And that's, again, one of the tests that has to go through your
Has to go
office,
through me as a bottleneck to be allowed.
Okay. And if it's positive, then the patient would be treated, taken care of. And would you then, if it were positive for Ebola, would you go back and trace all the contacts?
Well, first, you know, that's a two-part question. It would be positive through our test here, but then it'd have to be confirmed at the Center for Disease Control. Okay. And again, if the person was in the early stage of their disease, we might get a second test within 72 hours. So before that. Meantime, the patient still would be isolated and would be given, you know, care. There's actually no treatment for Ebola except for maintenance of body systems.
Which works remarkably well.
Which has been working well, although there are some experimental treatments using different drugs. Actually, one developed in San Diego, and some places where they're using autologous blood transfusions. So we are doing some things that are not necessarily FDA approved at this point, but are being used to treat some of these patients.
And then if this patient had contacted others before being febrile, would you do anything about that? Or?
Oh, yes. We have extensive contact tracing forms. Obviously, we have about 40 forms, depending on, we have contact tracing for their pets. We have protocols for pet exposure. We have more protocols than can fill a lot of cloud space. So let's just put it that way.
That's why you said you're taking on the dogs yourself?
I'm taking on any dog for Laurene's Pet Haven because I feel sorry that no one wants to take the pets. And at this point in time, there's really no science to say that pets can transmit disease, but there is a little bit of, fear. So
yeah, we just know that they make
have
antibodies.
They have antibodies, so I'll take them.
So then this has been a controversial issue with respect to the doctor in New York, because people say, well, he shouldn't have been running around because he was from an at-risk area and he should have known better. What do you think about that?
Well, that's an interesting question. I mean, the feeling is you're not infectious till you have a fever. And I think that people should, look again at that Dallas case. He was actually living in a household for 4 days before he was hospitalized. He was with his fiance, he was with his the children, and he was with a lot of other people. No local contacts got the disease. Once he got febrile and even was admitted to the hospital, then there were transmission to healthcare workers, but there's no casual transmission of this disease. And usually once you're febrile, that's when all bases are off and you get hospitalized. So yes, there have been some governors that have currently gone out and said to the state right now, that have said in New Jersey and New York that any person who has been in contact with an Ebola patient is on home quarantine and is not allowed to go out. Now, other people disagree with that, and I know in New York City they're currently not following that. Because again, the science does support you're not infectious till you're out. However, the fear factor of knowing that this gentleman went bowling or did what other things obviously is causing a lot of panic. So I guess as a politician, I'm not knocking them, you have to weigh the public's perception versus the science.
Sure. There's also a discussion in New York City, it was in the paper, the New York Times today, that quarantine is a violation of civil rights. I don't know if you've seen that, which you must find amusing, I would guess.
Well, I mean, we actually have that health orders that are okay for us to quarantine people if they pose a risk to the general public's health. So we already have, quarantine orders for TB patients, for multi-drug resistant TB patients. So we have legal orders and standing regulations for that. So people can talk about the ethics of, quarantine, but again, there is a bigger picture.
Yeah. It's very interesting because on the one hand, many people are afraid and they express outrage that we're not doing enough. And then on the other hand, people criticize you for quarantining. So you can never win.
You can't win.
Yeah.
You can't. That's the bottom line. So this is a very interesting point. This incubation period, which you said it looks like you're not infectious until you have symptoms. Many people, I get lots of emails about this. Many people want to know, how do you know that? And it's not an easy question to answer because, as you alluded to in your talk, we don't really have all that much great data.
That's correct.
We have what we've observed in previous outbreaks, right? And you seem to have to contact someone to get infection.
Right, and I think, as I said before, in this developed country with our latest cases, we're demonstrating that exact fact that no local contacts of people that have been walking with Ebola, be it the 2 healthcare workers from Dallas or this gentleman, although we still have the 21 days, or one of my friends who volunteered to work in Liberia and then came back for 21 days and self-monitored, have actually, transmitted the disease until they actually got infectious. And again, except for some certain diseases like influenza, where we've actually monitored people to see that they are infectious the day before they get a fever, not all diseases are infectious until you actually start multiplying those little viruses or bacteria in your blood, which show symptoms. So it does make sense from a pathogenic point of view.
Well, I think, as you said also in your talk, hopefully we can get some virus load information from people in this country and address that.
Exactly.
Because if someone is known to be exposed, we could then monitor them and see what happens to virus levels, if they're shedding any virus and so forth. And that's something can't do in Africa because
Right.
usually it's a crisis situation with hundreds of cases, right?
And the other thing is, too, just because you have the virus doesn't always mean you're infectious. I mean, it's the same thing about finding the virus in the environment. People always sort of get, freaked out when they say you can get something from toilet seats. Well, my mother never told me you can get anything from toilet seats. But, I mean, we kill so many trees because of that. But, I mean, the thing of it is just because you find it in the environment doesn't mean it's infectious. I'm sorry I had to get that plugged
No,
in.
it's fine. You can use this as by the way, we have microphones wandering around. So if you have questions, Beth will find you, and you can be part of TWIM. Okay, so think of something, and you can ask our two wonderful guests here. So what do you think? Do you think you will eventually, given the nature of the infection growth in Africa, do you think eventually you'll get an Ebola patient here in California?
I don't ever want to say never. I mean, I think that there's always a possibility. In a weird way, I almost hope we would, in the sense that I hope we have enough people that go overseas and volunteer to work with Ebola patients to the degree that maybe someone does come back. But on the other hand, I obviously don't want anyone to come back with Ebola in the United States. But it could be possible that someone could be visiting someone here in Los Angeles and not be aware that, like that other gentleman who was not aware that he had come in contact with a patient, and that's why he wasn't under extreme radar, so to speak.
Right. So as an epidemiologist, what do you think we need to do to stop the epidemic in Western Africa?
Well, I think it's pretty clear that they need infrastructure support. They've needed infrastructure support for years. Médecins Sans Frontières have done an excellent job of working over there for many, many months, to the point of exhaustion. And again, though, we need hospitals, we need supplies, and we need open channels to get those supplies to the people, because, like, as I said earlier, there's a lot of also civil unrest in those countries, and sometimes aid doesn't always get to the places that need it. So I think, the degree to which they need infrastructure over there cannot be really enumerated.
Some people have said that only a vaccine will stop this outbreak. Do you think that's a reasonable statement?
Well, that could be a possibility, but vaccines take a long time to go through trials and stuff, and I know that we're pushing this one through rather fast, but it's hard to say. Vaccines against viruses are very tricky.
And we're only doing a phase 1 for safety,
right.
so even if it's safe,
we don't know about efficacy.
And I don't know how you would do a controlled trial during an outbreak, right? You're going to keep half of the people not getting it? That would not be. That's the thing that Jonas Salk struggled with when he tested the first polio vaccine. He did not want to have a controlled group.
Right.
And he was forced to by his mentors, and they said, if you don't do a controlled group, it's meaningless, and he had to do this. We have a question? Yeah, wonderful.
I would like to know which hospitals in Los Angeles are capable of handling an Ebola patient.
Well, at this point in time, we like to say that all 100 hospitals are able to evaluate, diagnose, isolate, and protect their healthcare workers from a potential Ebola patient. But the narrow list of hospitals that are being worked with extensively, really at this point in time, except for UCLA, the UC Systems was announced by the governor the other day as being designated Ebola hospitals. So obviously UC San Diego, UCLA, and some of the other UC systems have been outed more or less as being designated hospitals. But we do have other hospitals we're working with that actually we would like to keep, in-house, because, there's more publicity that gets to them the less time they have to prepare. You're welcome.
Is there anyone else from another health department in the state that does Ebola at this meeting? Raise your hand. You did. I talked to you last night, right? Yeah. Anybody else? No? Okay. Anything else we should mention? You want to get on a soapbox for anything
Get your flu vaccine. So this way, when you get those fever, you won't think you have Ebola. I mean, it's get your flu vaccine. Yes, there's a question over here.
So in Southern California, I think that the Public Health Department has really responded with professionalism and vigor to really help all of us in the healthcare setting to really become prepared in the eventual case that we have somebody walk into one of our hospitals. And obviously, you're constantly, responding to, swine flu, large influenza outbreaks. But how has this impacted your ability to really respond. You're working 100 hours a week. LA County is bringing up PCR testing. You wonder, do you really have the federal and state support to respond to something like this? How does that look for the future? Maybe it's a little bit of a political question, but certainly we all support public health and want to see you be able to respond to us because of what we need. But what does that really look like for you in terms of
the landscape? I think the landscape is we never have enough money. I mean, obviously, public health is always underfunded. And even when we talk to the current hospitals that we have online for preparedness for an Ebola patient, they're looking at 1 or 2, patients per hospital because of the amount of resources that it's going to take just to care for those 1 or 2 patients. When you think of the more than 200 patients a week that are hitting the Liberian hospitals, you can imagine what type of resources that would take. So, are we prepared? We are prepared. If we got hundreds of cases like in a third world country, we would be in dire straits. But I think luckily we would have the ability to know about appropriate use of personal protective equipment, but what we're seeing already is that there are back orders on those because, again, a lot of the worried well or the people that don't need those equipment are ordering them. And so, again, it's good to have free enterprise, but that also means that anyone and everyone can get whatever they want. And so there are some shortages. I know a lot of point-of-care testing as it relates to for laboratories, a lot of hospitals aren't used to working on because we're talking about dedicating, obviously, laboratory testing if we had an Ebola patient. And again, so there are some lessons that are being learned with this preparation, and hopefully these lessons will translate into a real-life situation, but hopefully not yet.
Yeah.
I actually have one question, and it's more of a scientific question as opposed to a political question. But you said there's 5 strains of Ebola, and I don't know if the science is out there yet, but do they know if you're exposed to one strain and survive, and then you're exposed to another? Is there immunity, or is there something like what you see with dengue, where if you've been exposed to one, it's actually worse if you see the virus, a different strain? Do you know?
Very good question. Yeah, if you are exposed to the current strain of Ebola Zaire, you are immune for life. There are, those 3 other types that can cause infection. But if you are exposed to the current strain, once you survive this strain, you'll be fine.
But what if you're exposed to the other strains?
Then there is not. There might be some cross immunity, but obviously there's not going to be full immunity.
Yeah, in non-human primates, there's no cross protection. So the current vaccines, if you wanted one vaccine for all, you'd have to have a blend of a couple of different constructs. I'm glad you mentioned flu, because I was going to say when flu season starts, you're going to have a rash of people coming in saying, I have Ebola, right?
Well, we actually were trying to develop a document that said, how do I know if I have the flu versus Ebola, which I thought was actually pretty silly. But, people I'm sure are going to say, I just came back from anywhere and I have a fever and a headache. How do I know if I have Ebola? And again, we always say that Ebola presents very non-specifically. There's a lot of protean symptoms, although more likely than not, if you get a fever, it's not. If you look at the studies, albeit from Africa, almost none have runny noses, and only about 20% say they have a cough, a sore throat. And on a lot of those, the cough, especially because they're from countries in Africa, that cough could be representative of tuberculosis or some other chronic condition. So I think if you've got a runny nose, a sore throat, and a fever, you have the flu or some other respiratory virus until proven otherwise. And you can get a quick test for that. You don't have to go through me. You can get a test for that from your private doctor. But if you get a flu vaccine, what I always think is interesting is that all the anti-vaccine people who don't get pertussis vaccine, who don't get flu vaccines, would be lining up around the corner for that Ebola vaccine, and no matter how many side effects it had.
Well, I think you're the right person in charge.
Thank you very much.
You sound great.
Thanks.
Let's move on to David, as we're time constrained. Can you explain, without slides, just with your voice? No, it's hard, because your slides are great, how this wonderful PCR machine that you built, you call Gene Expert, right?
Yes, yeah.
Where you just need a cartridge. You don't need me changing tubes from water bath to water. Can you tell us how that works?
Yeah, so it's a self-contained system that involves a cartridge. It's plastic. It's injection molded plastic. It's assembled on an automated line, and then it's filled with reagents that contain PCR-specific reaction components. And then there are 2 moving elements within the cartridge. One is a valve on the bottom that moves between chamber to chamber. It allows liquid flow between chambers. And then there's a top element that engages a little a syringe like a stopper. And that actually is engaged from the outside through the top of the cartridge. That allows liquids to be pushed and pulled through the cartridge from the outside. So there's no contact with the inside components of the cartridge. So those things allow for all kinds of stuff to happen inside the cartridge, ranging from you know, reverse transcriptase PCR for RNA virus detection to TB detection, and you can monitor them using real-time PCR technologies, which allow for self-contained, relatively contamination-resistant approaches to doing PCR. So it truly is a technology that democratizes the ability to do what you and I used to do, you know, 20 years ago. It was really impossible to do outside of a highly controlled environment. Now it really makes it possible to do it within that highly controlled environment, but within a cartridge.
So it's a single cartridge, which is, depending on what you want to assay, it's manufactured for TB or for anthrax, right? And then it's slid into a larger machine. How do you add the sample to this then?
So usually just the sample is added through a single open port in the top of the cartridge. You open the lid, there's a hole in the cartridge, you just add the sample to that. Or you can add a swab, and then it just gets processed in that sample port.
All right, so then the sample's taken into this cartridge and the PCR reactions occur. And then how do you get the data out about what happened?
So the data is actually occurring by real-time PCR. So you actually watch the so-called growth curve of the PCR reaction process. You can see a cycle threshold value when, if you have a lot of bugs on board, you see an early detection event, you know, at maybe 15 or 20 cycles, and then if it's low positive, it's a later detection event. That actually allows you to quantitate very accurately as well. And you look at the fluorescent probe signal that's generated inside the reaction tube that's attached to the cartridge.
And the fluorescent binds to the DNA basically, and that's how you quantify it.
Yeah, it's a fluorescent probe and a quencher, and they bind to the amplified target. And there's quenching until the probe component is cleaved, and that is liberated in a solution. That makes fluorescence happen. And that's how you detect it.
And you were talking in terms of rifampin gene and TB, that you can see alleles by using different colors. Is that right?
Yeah.
So you use different colored dyes?
Yeah, exactly. So we use 6 different fluorescent dyes, most using a single quencher. And then now we have, through an NIAID-funded program, a 10-color version of it that allows us to use modified dyes, not modifying the hardware, modified dyes, to increase the number of channels we can detect. And now we can do high-resolution melt analysis in the system to really dig deep into the sequence data and include even more targets. So theoretically, we could go after 30 or 50 targets within one cartridge.
I'm just thinking, you know, avian flu is being monitored for changing to certain mutations that may increase transmissibility. This would be a great application of that, right?
Absolutely, yeah. That's really, and I think that the ability of this, we talked about the surveillance capability of this technology too, and I think the ability to really identify sort of your usual suspect during the course of the season, but then having the backup capacity, even though it may not be reported as a patient result, if you have the ability to monitor that channel that's avian flu specific or, you know, Tamiflu resistant specific, you could really add color to the emergence of local outbreaks of new infections. And
amazing.
In fact, I think there's a good case to be made that in the U.S., for instance, you shouldn't be reporting out an avian flu result, you know, to the patient or the physician, because it'll create, you know, hysteria. And in a country with 0 prevalence, then every result's going to be a false positive if it's positive. So, you know, I think there's a good reason not to do that. But you really would like to have public health access to that data in the cloud, actually seeing it, and if you see clusters of cases that are happening that indicate something more than just random false positivity, that really could add some credibility to the results.
You have one of these machines?
We have a site in Los Angeles that does do that for us.
Yeah.
So you could make an Ebola test with it, right? You can have it a cartridge.
Theoretically, yes. Yeah.
Or anything, chikungunya, dengue, whatever you wanted.
Yeah.
So then also the data, as you said, can be uploaded to the cloud and could be accessed by health departments.
Right.
CDC could get it, right?
We don't want them to get it.
You don't want CDC?
But no, we need to get it first. Then we'll let them get it.
Yeah, it's a good.
Well, you should both get it.
And you have it. Yeah.
Right.
Yeah, you get the first look.
We get the first look.
Yeah.
And you now have how many of these machines globally? You mentioned
there are about 7,500 globally, and there are about 1,700 or so in the U.S. And so that's a pretty high resolution, map.
You called it a heat map. I thought that was neat.
So, and the more that are out there, the more surveillance capability you've got in real time in terms of geopositioning and localizing events.
But no single agency has access to all the data coming out of all these machines, right?
Well, I mean, the NHLS in South Africa has access to every TB test result being generated in real time on their patient population. WHO may at some point be able to work with countries to be able to access the data so they can have a global snapshot, and we can enable that to happen as well. So I think ultimately for diseases of public health interest, that's going to happen. It should happen. Same thing could happen for avian flu or for Ebola or for other things where you really do need case clustering in real time, and because of the need to understand what's happening on the ground at that moment.
I'm thinking in terms of polio eradication.
Right.
There's a need to monitor sewage and viruses in the sewer, especially when we no longer have polio. We're thinking of stopping vaccinating.
Right.
And right now, it's done by sequencing most of the genome, but this could take care of it as well with your 10 or 16 colors.
Yeah, we do have an enterovirus test on the Gene Expert, and it's used primarily for meningitis management. It doesn't call out EV68 separately, but it doesn't confuse rhinovirus and enterovirus, so it actually is enterovirus specific. It has been used in places where EV71 outbreaks have happened, where the paralysis is even more common.
Right, exactly.
So I think there's some potential there for that to happen in sort of a surveillance mode as well from environmental specimens.
So what's the smallest machine that you can buy?
Smallest is a single module system.
It's like this size of a bread box.
It's this tall. Just very
So this could go in a physician's office.
It could. Yeah.
How long does it take to get results? An hour?
Anywhere from a half an hour to 2 hours, depending on the test, depending on the complexity. But and we're moving to faster and faster because it's actually the shorter the time the cartridge sits in the system, the higher the throughput of the system. So we're moving to faster and faster turnaround times. But we're seeing like group practices in medical office buildings begin to bring in this technology for flu, chlamydia, gonorrhea testing. Different practices will have a different favorite on the list, but they'll begin offering the testing locally, and there are many benefits to doing that. And of course, but here again, it's trickle up from a mobile van operating in South Africa to really kind of be pushing the envelope in terms of where the technology can go. And I think that's, but ultimately we're going to see a lot of decentralized testing where it makes sense, where the results need to be acted on quickly. That's where we're going to see it go.
Now, you made a point of saying how it's easy to operate this machine. It can be done at a post office, in fact.
Yeah.
But someone needs to know how to read the results, right? So that's the key part, I would guess.
Yeah, absolutely. The results need to be simple, and I think that's especially when you go into a lower complexity test environment, lower skill sets operating the test. You have to make the test very simple. So actually, we just started a clinical trial with our CLIA waived flu RSV test which is the same cartridge as the moderate complexity test, which is now pending regulatory approval. The CLIA Wave version of it uses a touch screen computer that's very simple to operate, that has very simple readouts. And it's, so we expect that it'll get even simpler in terms of operation and result delivery.
So what's the readout? If you do a flu RSV cartridge, is it going to say flu positive? Will it get granular and tell you which strain? Or
Yeah, it'll tell you flu A, flu B, or RSV.
Okay.
Yeah.
It's amazing.
Yeah.
You must love this, right?
It's great. It's real time, and it's there, and it's good for the clinicians, and it's good for surveillance.
Yeah. So is it going to get any smaller? Because a handheld device would be neat, right?
Yeah, I think, you know, we're always looking at ways to enhance things, improve things. It could, but right now we've got, you know, I think what we need in terms of scalability. The nice thing about it is you can be running a small system or a huge system with 80 modules and a robotic arm that does all the work. And it's the same cartridge, same result, same sensitivity, specificity being operating from a clinic in a mobile van, or a mobile van as would be a big central testing facility. So the results are harmonized relative to the performance of the test. There's some minor levels of operator variability, but those are usually picked up in the controls. The controls will come up negative. Every reaction has, in our TB test, and based on our anthrax experience, we actually make a little lyophilized bead that's got Bacillus glabigii spores in it. That bead gets put into the sample as soon as it hits the sample chamber, and it gets carried through the process of extraction, amplification, detection. So we have to lyse the spores with a sonic horn. We've got to get efficient recovery, detectability of the sequence. If that fails, that says, hey, there was a clog or too much, you know, muck in the sample, so that the whole sample's analysis was in doubt because of that. So that's the kind of control you need to be able to operate in these kinds of extreme environments.
I want one for my home.
Yeah.
I want every week to test my body fluids for various things.
I think
not that I'm not paranoid. I'm just curious.
No, I think it could go there eventually. I mean, just think about it. You're a mom at home. You've got a kid with a sore throat, okay, or maybe flu's going around, right? And you have a module. This could be any system, right? But you have a module built into your Samsung refrigerator. And okay, it's right next to the ice dispenser, okay? And it's got a touch screen, you know, computer on the door of the refrigerator. So that's, you operate it from that. And you then your kid gets sick, and you call Amazon to deliver by drone a cartridge to your front doorstep.
I love this guy.
All right? You collect the specimen, you run the test, and then the result gets sent wirelessly to the pediatrician's office.
Thank you.
Okay? Mom doesn't even see it, right?
Absolutely.
Okay? It goes to the pediatrician, they get an alert that says so-and-so was flu A positive, and along with it is the patient's phone number that they just have to press to call the patient and say, you know, we need to do something or not.
Don't go to school.
Yeah,
Don't go to
right,
school.
exactly.
When is this going to happen? Is it 10 years or much longer?
I'm a dreamer, so I usually add, you know, an extra 10 years to.
Yeah.
I think it could happen within the next decade. We could see home testing in certain applications. It can't be a venipuncture-based test.
Yeah,
it's got to be a swab or maybe
you could do a
finger stick capillary specimen. Right? Yeah. We have the Dean Street Clinic that I showed, the big MSM clinic. They would like to do whole blood testing in real time in the same clinic for early detection of acute retroviral syndrome in those patients. And you know what, you might see that kind of continuous monitoring activity go to the home setting as well. But that, here again, that's dreaming. You don't want to be delivering to the Samsung refrigerator you're HIV positive. But
like
you do want the results to go to somebody who can work with the patient to help them understand what's going on.
So could I buy one for my home right now?
No.
You're not allowed to buy one. Huh? I could build. I'd have to build one.
Well.
Why don't you just don't want people having this information?
This is a laboratory system, and the CLIA wave, even the CLIA waived versions of what we're going to be making will need to operate in laboratories. I'll have to have a CLIA.
Well, I have a lab, so I could buy one for my lab, right?
Maybe.
Maybe. Yeah. I have good experiments to do. Yeah. I think it would be very interesting to know on a weekly basis. I'm interested in what our virome is, and our saliva, our other fluids, and so forth. And this is a perfect way to do it. Yeah. But you'd have to make a cartridge that would do a broad survey. You could do that.
That's right. Yeah, we could. Yeah. So broad spectrum, broad range, syndromic diagnostics are the future.
Sometimes be aware of what you get, though. I mean, sometimes there's some information you may not want to know.
Well,
some things are better not know.
I'm a scientist. I want to know everything.
You want to know everything?
Yeah. But everybody's not like that, I understand. But any questions? But we only have a few more minutes. But if you have a question, you should queue it up here. So is this kind of machine used in the post office to scan for anthrax spores?
It is, yeah. It's actually built into a cabinet that was manufactured and developed by Northrop Grumman, which is the maker of the postal sorting equipment in the post office. So they manage the whole program in terms of integration of the gene.
But it's your machine that's in the cabinet.
Yeah, it's inside. It's the Intel inside.
Tell us briefly how it works. Oh, there is a question? Okay, we'll go to him first.
Hi. So a couple of days ago, I was at a screening of a documentary about antimicrobial resistance.
Yes.
After the movie, there was a panel discussion, and one of the ID physicians that was in the panel had mentioned that one of the reasons why sometimes antibiotics get prescribed when the patients don't really need it is because of the fear that the doctors don't want to be wrong about their diagnosis. And sometimes a patient would have a flu, and they end up prescribing antibiotics anyway because they're not sure. Right. And I guess one of the things that would actually help get rid of that fear is to have diagnostic tools like this at the clinic in the exam room. And I would like to get your opinion about how far are we from the possibility of having that in a healthcare setting, in a typical healthcare setting.
Yeah, I think it's really it's a trend that's going to continue. I think one of the messages we're talking about Ebola testing, and there's a far greater likelihood of a patient with a flu-like illness that they actually have the flu than that they have Ebola. So one of our best roles in microbiology and in public health is to actually rule in the flu, to rule out everything else. And the same thing for patients who vomit. I enjoyed your comment about the drunk on the plane. I mean, I think, if you have a turbulent flight, you're going to have loads of patients coming in vomiting, and the bottom line is, what do you do? And I think, rule out or rule in norovirus, or rule out other more obvious.
Alcoholism.
Do an alcohol level.
Right.
But the bottom line is we can play a supporting role in terms of ruling out much more frequent, much more likely causes. And this is the same example: is that we can rule in something effectively, we can rule out other things. That I think the whole issue of antibiotic surveillance is critical, though, and this is where I think this kind of technology with detection of, let's say, carbapenemases in gram-negatives, and being able to monitor that activity in the cloud in real time, would by geopositioning. I know that hospitals are going to be sensitive, that they're going to be pinpointed on a map as having, 5 KPC cases in a week, but for public health, having that kind of information would be extremely valuable, and I think that. That's where this is going to go eventually. It may be something that hospitals can't see, but public health can see and deal with it appropriately.
So in 1 minute, I want our listeners to hear that. What does the post office do to look for anthrax spores?
Right now, they sniff the mail as it's being sorted in about 160 plus mail sorting centers. The mail gets sorted into different bins for distribution according to zip code. They hold the bins until the green light goes off at the top of the cabinet. After that, anthrax test is performed, and the mail's good to go. That's happened 13 million times over the past
So the mail
years.
is held until the test is done,
Yes.
right? It's an hour, and it's done every hour,
It's a 38-minute test. It takes about an hour to do the whole thing. So it's an hourly event, a little bit less than an hour, but it goes off periodically, and it's good to go.
And you said this is a test which nobody knows about, and you're right.
We know about it.
You know about it?
Yeah.
I know about it.
And she hasn't had any false positives.
Thank God.
So,
I've had no false positives.
Yeah.
But we practice all the time. It's called BDS,
Wow.
the Biohazard Detection System. And we
Right.
have one in Los Angeles County. And we practice the drills if a thing goes off in the middle of the night and how we're going to respond, et cetera, et cetera. So thank you for not having false positives.
Yeah.
So this is
You're welcome.
in major cities, I would guess. Not every post office has this.
Right. Yeah. It's been cut back a little bit from its original distribution down to the major metro areas where
Right.
these events might be more likely to happen.
Well, we're out of time, right? Okay, I'll wrap it up now. We'll have to do this again, right? We can do that. So this episode and all the others are at microbeworld.org/TWIM. You can also find us on iTunes. And we normally do email. And if anybody has questions, they can send them to twiv@twim.tv. And I want to thank both of you for joining me today. Laurene Mascola at the LA County Department of Health, thank you very much.
Thank you very much
It was
for having me.
fascinating. And David Persing at Cepheid.
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 What is it?
Cepheid.
Cepheid.
Cepheid, I'll get it. I'll get
It's
it one
Vince-
day.
The
It's
accent's
Vince
on the second syllable.
Racaniello.
No, it's not
It's
Racaniello.
Vince Black and Yellow.
Black and yellow, that's how you remember
how you remember
my
his name,
Well,
yeah.
what's the key for Cepheid?
Black and Yellow.
Cepheid.
Cepheid. I just did it.
Listen,
Okay.
if you're in the UK, it's Cepheid.
Oh, my God.
No.
There you go.
Oh, in the UK, it's encephalitis, right?
Encephalitis, yeah.
Encephalitis.
So,
Thank you very much for
You're
joining
welcome.
me. I'm Vincent Racaniello. You can find me at my blog, which is virology.ws. On Twitter, I am Prof. VRR, PROFVRR. I want to thank Beth Marlowe for having me, SCASM president. That was a great idea.
Thank you for coming.
You're welcome, and all of SCASM for having us. Thanks to the audience for coming here. And I want to thank the American Society for Microbiology for their general support of TWIM, in particular Chris Kandian and Ray Ortega, and that's Ray over there on the camera. Ray is a professional podcaster. You can find him at thepodcasterstudio.com. Thanks for listening, everybody. We'll see you next time on This Week in Microbiology. Thank you.